I'm Associate Professor Len Kliman. I'm a specialist gynaecologist working in Melbourne. I thought I'd start off with premenstrual dysphoria disorder. It's a disorder that's not well understood, and there aren't a lot of people who concentrate on this as a disorder, but it has a major impact on the lives of many women. So I think everyone knows of premenstrual syndrome, where 85% of all women in the reproductive age group would get one symptom or more, usually breast soreness, fluid retention, mild mood disturbance, and that's quite common. But there is a much more severe version of that condition called premenstrual dysphoria disorder, where people have a number of symptoms that interfere with their quality of life. And the sort of symptoms we're talking about are severe depression, anxiety, being emotionally fragile, finding it difficult to interact with other people, not being able to sleep at night, finding avoidance behaviour where you want to stay at home, you don't want to interact. You might even find it difficult to interact with your partner or your children. And that especially occurs in the second half of your menstrual cycle. So that means for half of your life, you have symptoms which are distressing and sometimes disabling. To why people get premenstrual dysphoria, we don't know the exact cause. We believe that probably hormones interact with what we call neurotransmitters, or chemicals that send messages in your brain. And some of those chemicals are estrogen or female hormone dependent. That may explain, for example, why people get mood changes when they're pregnant, mood changes when they're menopausal, but also probably explains why people get mood changes premenstrually. I always tell my patients that if you have symptoms that interfere with your quality of life, it's important that we do something about it. There are a number of treatment options. The first are antidepressants, and there are a group of antidepressants called SSRIs. They're frequently used. They have about an 85% success rate in improving symptoms. Not everyone likes the idea of taking antidepressants. If you're having symptoms that interfere with your quality of life, you need to do something about it. Scientifically speaking, there are a number of studies where these drugs have been used, and people will have heard of Prozac or a drug called fluoxetine. They would have heard of Zoloft or a drug called sertraline. And there are a number of studies using these agents either continually or just in the second half of your menstrual cycle to try and improve premenstrual dysphoria symptoms. The other alternative is to stop your periods altogether. And the common way to do that is to take an oral contraceptive pill continuously so you don't have periods. There's good evidence if you stop women from cycling, they won't get premenstrual dysphoria disorder. And I like using a couple of pills that have more natural-based estrogen rather than the stronger synthetic estrogens in the older-fashioned pills. And women who take these continually often find an improvement in their premenstrual dysphoria disorder. There are more complicated ways of preventing yourself having a cycle. One is to have an injection every month that inhibits the release of the hormone called GnRH that actually gives you a menstrual cycle. And when we do that, we give women estrogen hormone as well, because the actual injection puts you into almost a menopausal state, and that's associated with side effects. So we prevent those side effects by giving you estrogen to make up for what you're not making yourself. We use that as a last resort. We try simpler treatments first. A typical appointment where I see someone with premenstrual dysphoria disorder, first of all, they often have a history of depression or eating disorders or ADHD or some sort of psychological or psychiatric problem in the past. Sometimes they're already on treatment. I don't think as a gynaecologist I should be caring for these women by myself. All of my patients I refer to a psychologist and psychiatrist because they need ongoing support of their symptoms. Psychiatrists have a better knowledge of antidepressant medication. So I think it's a team effort. It's a psychologist, it's a psychiatrist and a gynecologist all working together in the interest of the patient.